This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 3, Heart Failure, and key concepts on this chapter. Upon completion of this chapter, you'll be able to understand the effects of heart failure on the patient and society, methods to identify, assess, and manage a patient experiencing an acute medical emergency due to heart failure or device failure, technologic advances such as LVAD, LVADs, or left ventricular assistant devices, intra-aortic balloon pump, bilevel, and CPAP, which is BiPAP air and CPAP air. Alright, so chief concerns, just a general overview here. We're going to talk a little bit about the cardiac cycle. Let's see if I can get this up and running. So, first of all, the patient would have impaired heart function, and this could be from a multitude of things. So, whatever got them there to give them impaired heart function to begin with. If this is dilation of the ventricles because of cardiomyopathy, if this is a heart attack that give them low ejection fraction, it could be a multitude of things. Whatever the reason that caused this, it reduces cardiac output. Now, cardiac output comes in a formula, but it pretty much the simple answer on cardiac output is it's the blood that's pumped from the heart. Vascular resistance is involved in that too. I generally tell my students, and I'm going to switch colors here so everyone can see this since I'm off to the side, that there are three things. How about I just blank the screen? There are three things that make cardiac output up, and that is heart rate, contractile force strength, and peripheral vascular resistance. Now, this is like in a triangle. So if one of them fails, the other two make up cardiac output. So the vessels squeeze themselves down and the contractile force may increase a little bit due to automaticity to try to increase the blood pressure. Now, in the middle of this triangle, you have to have an adequate amount of fluid, or none of this works. Cardiac output equals heart rate times stroke volume. This is what goes into your equation for stroke volume. Is their heart rate adequate enough? Do they have enough contractile force strength? How is their peripheral vascular resistance? And do they have an adequate amount of fluid in play? So, impaired heart function from whatever reason. Cardiac output is decreased. Well, if your cardiac output is decreased from any one of those problems, then the organ perfusion itself becomes decreased. This is going to activate survival mechanisms within the body, fight or flight being one of those, which is our compensatory mechanisms. The thing that the body does is it has short-term and long-term responses. In the short term, the easiest fix on things is, hey, let's just soup this up. Let's dump a bunch of catecholamines or epinephrine and norepinephrine and get an increased heart rate, contractile force strength, and squeeze down on the vessels, all in one swoop. The long-term version of that is a talking to, essentially, from your brain, your kidneys, your heart, your vasculature, and it's the renin-angiotensin system, and we're going to talk about that a little bit in detail here as well. So, all of this extra work to try to maintain your cardiac output increases the cardiac workload, which now turns a heart that's fairly efficient into a gas guzzler, if you will. So you don't get enough bang for your buck. So all of our goals and all of our treatment plans that we put into this to try to correct this, very simply reduce myocardial oxygen consumption and increase the supply. Now, sometimes the answer is on this is they need a new heart. Clear this off. Pathophysiology of heart failure. Heart failure effects is pretty much dysfunction of the myocardial contractility in any form or fashion. Contractility is the ability of the muscle cells to shrink and contract. So they just have a very simple job in this. They have to be efficient, but they need to contract. Gender development of heart failure. Compensatory response by the sympathetic nervous system and the renin-angiotensin-aldosterone system are important responses, but are only meant to be temporary. The problem is if we get this continuously, is now we have pathophysiology in play that we can build diseases off of, and we'll talk about that here in just a second or two. So, the autonomic nervous system response is the quick version. Let's dump catecholamine, let's make the heart beat harder, faster, stronger, and squeeze down on the vessels and make the heart beat faster and increase cardiac output. Well, if that doesn't work, then the renin-angiotensin system comes into play. The end result on this is angiotensin 1 is converted into angiotensin 2, and this causes vasoconstriction. Now, the vasoconstriction that's caused from this, right here, is kind of a longer term effect than the adrenaline that we get from our kidneys or on the adrenaline gland. So what we get from this is a more sustained response to increase in cardiac output. That almost becomes our own worst enemy at some point. The increased squeezing of the vessels decreases the lumen and can possibly give us atherosclerotic plaques built up because of the lumen smaller. If we have fat built up inside of those vessels already, very simply, it only takes one platelet to start to stick, and then we got a whole accumulation of them. So angiotensin 1 to angiotensin 2 essentially squeezes down the vessels for a more long-term response. That also increases the afterload effects on the heart. Now I'm going to go back kind of to the slide on this, or the whiteboard. Now, this is the aorta coming out. So if I squeeze down on the vessels in the distal areas and increase the amount of pressure, the heart itself now has to squeeze harder to eject that blood out. Afterload is the pressure at which the heart must pump again. So it's the pressure that's residing in the aorta whenever the heart ejects its blood. And then other hormonal responses. Other hormonal responses are things like antidiuretic hormone from the posterior pituitary, no-pene hormone, which increases hypertension, scars the vessels, fats can stick, atherosclerotic plaques develop, decrease lumen of the vessels, and so on. I could go ... on that. Endothelin is another hormone that they talk about, potent vasoconstrictor that is released by the endothelial cells. Ventricular remodeling. Now, the heart is a muscle. So whenever we start talking about ventricular hypertrophy, it means exactly what it says. The heart now, since due to its increased workload, has had to get a little bigger. Well, it only has so much real estate to live inside the chest on. So what we generally get from ventricular hypertrophy, or an enlargement of the heart, cardiomegaly, if you will, is the heart becomes larger to a certain point, but it kind of grows inside. Well, if I don't have an adequate enough chamber for the blood to go into, then very simply, the hypertrophy that has occurred has now decreased the amount of blood that I can actually fill in my ventricles. So, if I had a ventricular wall, and it was this thick to start with, that would give me a good supply to have blood go into. Now, let's say that after hypertension, after repeated years of angiotensin 2 and vascular constriction, antidiuretic hormone, the hypertension, all of this is like a domino effect that has caused my heart to become thicker and larger. Well, that just reduced the amount of filling that can occur in this ventricle. So now I have a reduced amount of what's considered ejection fraction. Continued progression of ventricular remodeling, your body responds to things. Half the disease processes that we see that are problematic are responses to physiological changes that the patient, or environmental changes that the patient has put upon themselves. An example of this, as the continued progression of remodeling occurs, blood flow to the area diminishes. This can actually cause, if the disease pathology of the atherosclerotic plaques continues, it can cause necrotic tissue of the heart, increased myocardial oxygen consumption. Your heart's a gas guzzler. Apoptosis or cell death can occur in the final stages of this. Heart attacks, full-blown heart attacks, to where you have very large sections of myocardium that now are injured because of necrosis. The causative factors of heart failure are intrinsic and extrinsic, internal and external. Intrinsic causes are things like coronary artery disease, myocarditis, toxicity from substance abuse, metabolic insults on the body, and then cardiomyopathy. Cardiomyopathy is a very generic term that just means diseased heart. The extrinsic causes are things like pericarditis from an outside source, maybe trauma and cardiac tamponade, tachycardia, and the heart's inability to meet the circulatory demands placed upon it. Abnormal volume load on the left ventricle, caused by fluid retention, fluid overload, excessive vascular resistance, and chronic pressure overload. And this is a good time probably to talk about that a little bit too. We are all connected. And what I mean by that is the heart has a tube that essentially runs all the way around from oxygenated blood to deoxygenated blood. Now, we call this Mr. Blood Cell, that we take one red blood cell and travel it all the way through from its ejection from the left ventricle back to its entrance into the right atrium. If you're in heart failure, it's always going to spill fluid into the previous container. Now, this down here is the periphery, and the previous container for the left ventricle is going to be, I'm going to change color so we can see a difference on this, is going to be the lungs. Okay, just a quick review. Blood comes in here under low pressure on the venous side, deoxygenated. It is then, when atrial contraction occurs, goes into the right ventricle. We have a hole right here. There's more vessels in this, but this will get you the idea. Whenever the ventricles contract, we go one of two spots. Finish drawing this here. Okay. So either it's going to go into the lungs to be perfused with oxygen, or it's going to go out to the body for perfusion in the vessels. Alright, so what I said earlier was, if this is the right side of the heart and this is the left side of the heart, your fluid is always going to spill into the previous third space or the previous container. If we are in right heart failure, since this is a low pressure side, the previous container to the right heart is going to be the periphery. If you're in left heart failure, your previous container is going to be the lung tissues. So if you're in left heart failure, from whatever the reason, you're going to have pulmonary edema. If you're in right heart failure, you're going to have peripheral edema. Okay, so this is what it means here by abnormal volume load on the left ventricles. And as if we look at specific patients, I'm going to do one more heart here to kind of explain this, that have right heart failure that got them started. The simple model is this, is that as this pressure increases, or this back pressure, and we get stagnant blood supply and stagnation down here in the periphery and have peripheral edema, the afterload pressure on the arterial side increases. Now remember, the afterload pressure is the pressure that the left ventricle must pump against. So if this patient is more and more and more hypertensive, then very simply what we're going to get here is we're going to get it to the point, maybe, and this would depend on the physiology, that the patient's ejection fraction is less than the afterload pressure that's in the vessel. Now, very simply, what that causes, even on a hypertensive presentation, is pulmonary edema, or fluid filling in the lung tissue. Now, this is like a domino effect at this point that's going to crash the system. You can't carry oxygen because you have fluid. Your heart has an inadequate pump, and you are hypertensive or congested. And they come up with a term for that. It's called congestive heart failure. Pathophysiology Summary. Dysfunction of the ventricles depends on a couple things. The degree of neuronal hormone activation. So how many hormones do we have in play? The extent of the hemodynamic changes. So how far along in this disease pathology are they? Frank Starling's law, and this only works to a certain point, that if you stretch something to a certain point, it has a greater output. Well, that only works to a certain point. If we stretch something beyond that specific line of stability, then it does not have a greater output. It's its own worst enemy. And remodeling, including hypertrophy or enlargement, begins as an adaptive process. And this is a process that is essentially going through the steps of physiology to try to compensate for something. History. Figure 3.5 in your book, common presentations of heart failure. Fatigue, active respiratory distress, hypoperfusion. And this would depend on what type of heart failure you had. Table 3.5 is differential diagnosis. If you see somebody that is exhibiting signs and symptoms of heart failure, you should always keep these things in the back of your mind. Why are they short of breath? Could they possibly have a pulmonary embolus? Might they have pneumonia? Was there any fevers, productive cough, pain that goes away upon position, or pleuritic pain? Did they get into something that they were allergic to, like anaphylaxis? Did they aspirate on some stomach contents, which does not do well with the surfactant in your lungs? Are they in heart failure? Do they have trauma, or did they spontaneously have a pneumothorax? If they have syncope, they passed out. Syncope is like a wolf in sheep's clothing. Are they having an infarction? Are they having heart failure? Are they in sepsis, to where they're in distributive shock so bad that they can no longer maintain enough pressure to their brain to stay conscious? Have they had a hemorrhage? A cardiac tamponade? Each one of these things will give you certain specific signs that are different. AMI, chest pain that doesn't go away, localizes maybe on the EKG. Some chest pain or acute myocardial infarctions do not localize on the EKG. So clinical presentation, chest pain, diaphoresis, they generally cannot beat the physiology. Sepsis, fevers, no control over the vessels, or you think it's a distributed shock problem. And hypovolemia, there had to be 2-day history. There's going to be in the history as well. 2-day history of nausea, vomiting, and diarrhea. In hemorrhage, either they'll have a hot belly or they'll have a hot compartment where the blood is pulled into if you catch it early enough. Cardiac tamponade, pulsus paradoxus. They take a deep breath in and the radial pulse goes away. They have electrical alterons on the EKG. Tension pneumothorax. At the point that it becomes a tension, we'll have a mediastinal shift or tracheal deviation. There is a specific clinical indication for each one of these. So start off broad and narrow it down through your assessment. History of present illness, acute respiratory distress. Consider if they've had any kind of history of pulmonary disease, activity at the onset of shortness of breath. Were they doing jumping jacks or exerting themselves, or were they just sitting in a chair? Pain on inspiration. This may be pleuritic in nature. If they take a big deep breath in and it causes pain, that generally is not what cardiac symptoms are like. Nothing makes it better or worse for cardiac related. Are they a smoker? Do they have orthopnea? Patients with heart failures lie down and fluid returns into the pulmonary capillaries. Decreases the patient's ability to diffuse gases. So upon positional changes, do they have more shortness of breath, essentially? Cough and sputum. What kind of sputum is it? If a person has nocturnal dyspnea and wakes up in the middle of the night and has pink frothy sputum on their lips, there's a good chance they're in heart failure, and because of the position change, the capillaries couldn't recruit and couldn't keep enough pressure to keep the fluid at bay. Supplemental questions. Has the difficulty breathing or dyspnea been constant? Does anything make it better or worse? Have you ever had any similar episodes? Have the patient rate the dyspnea on a scale of 1 to 10. 10 being the worst shortness of breath episode you've ever had in your entire life. Where do you think you're at today? History of perils and illness, syncope. Considerations, onset activity. What makes it better or worse? Determine what makes the patient's symptoms, if anything, better or worse. Quality, what are they actually feeling, and have it in their words. Does it go to another region or does it radiate? What makes it reoccur, or has it reoccurred in the past? Severity on a scale of 1 to 10. And then what time the symptoms began. Associated signs and symptoms of pertinent negatives and allergies. Signs and symptoms for this. Urine output is always a good thing. Have you been peeing okay lately? What color was it? A lot of people will diurese at the point that they're hypertensive and trying to eliminate fluid. Their body's trying to kind of help them. Have they had any significant weight gains if their kidneys aren't functioning so well? If they've been in any kind of hemodynamic compromise. Patients who are hemodynamically stable may have an increase in urine output, but patients that are unhemodynamically stable, since it requires pressure for the kidneys to work, will not make good urine at all. Allergies, do they have any medication or food allergies? Are they allergic to latex? Anything like that. So get all of their allergies and their sample OPQ, ST, ASPN information as quickly as you can, especially if you're going to start slinging medications. Medications on these patients, they may be on these, they may not be on these. Some of these we actually use in EMS, things like nitrates. Nitrates causes a vasodilation to occur, which reduces the amount of preload that is going into the pulmonary trunk. Now, that would help a person that is truly in congestive heart failure. However, in the same breath, if a person is hypotensive, we would never use nitrates because we'll make them more hypotensive. Nitroglycerin patches, your patient might be on these. These are sustained release nitroglycerin that essentially is run transdermally. Angiotensin converting enzymes. If the patient is on an ACE inhibitor of any sort, this stops the progression from angiotensin 1 to angiotensin 2, thereby reducing hypertension. Diuretics, things like Lasix, or maybe potassium sparing, Buspar, things like that. Diuretics, the patient will probably be on. Lasix is the most common one that we see, or furosemide. Digoxin, if a patient has atrial fibrillation with rapid ventricular response and has ever a tachycardic episode with that, to where they're kind of unstable, chronically the doctor may prescribe them some digoxin. Digoxin does two things for it. It increases contractile force strength, or the inotropic effect, but it reduces conduction velocity, so it applies some control over the tachycardia, but in the same breath it makes their cardiac output more. So what we're going to see from that is we're going to see if they are in AFib with RVR and they've lost 30% of their cardiac output because they're in AFib, it'll increase their contractile force strength a little bit, and it will slow down their heart rate to allow for better filling. Beta blockers apply control over tachycardias. There are adrenergic antagonists or adrenergic blockers. The beta blocker, very simply, if you have a heart rate of 130, 140 sustained and it kind of stays in that realm, and you're having pump problems from ejection fraction, a quick echo from your doctor, and very simply they put you on a beta blocker and it reduces the heart rate, and then allows for better filling to occur. Past medical history. Let me clear this off here. Comorbid factors, things like history of acute myocardial infarctions, cardiac infections, trauma, atrial fibrillation. All of these would be comorbid factors that should be pulled into their medical history. Implanted pacemaker defibrillator. Please know when it was implanted, what type of pacemaker defibrillator it is. Most people carry a card with them. Hopefully they have it with them currently whenever they had the episode. If it's fired, how many times is it fired? Conditions leading to heart failure. Things like hypertension, if there's history of diabetics, heart valve damage, cardiomyopathy of any sort, any kind of STDs that might attack the heart, or obesity, morbidly obese. Substances, as far as alcohol, illicit drugs, things like that. Psychosocial, elderly patients may forget to fill their subscriptions or take their medications. Last oral intake, when did they eat last, and what's been the fluid intake is always good information to know as far as past medical history. On examination, determination of heart failure. If they have pre-established criteria, please be aware of that. So if they've had heart failure before, if they're already taking a medicine regimen, just be aware of what they're taking whenever you get the history. Scene survey, look for clues that may tell you that the patient's unable to care for themselves, untidy house, things like that. Initial assessment, symptoms, nature of illness, and mental status. Maintain their ABCs whenever we start off with the initial assessment. Very simple questions. Is their airway open and can they maintain it? Can they breathe adequately for themselves, or do I need to assist them? If I think I need to assist them, then do I have other options besides going directly to intubation? Things like CPAP and BiPAP should be considered. As far as circulation, do they have enough cardiac output, and do I need to deploy anything in my arsenal, so to speak, that would assist their cardiac output as necessary? Major criteria. This is Farmingham's criteria for determination of heart failure, and this is Figure 3, Table 3.9 in your book. Major criteria, Figure 3.11. is going to be paroxysmal nocturnal dyspnea, elevated jugular venous pressure, or JVD, and that was talking about earlier to where we would have a backup from the right side, rowels, or fine crackles, cardiomegaly, acute pulmonary edema, and S3 gallop. S3 is after S1 and S2. S1 and S2, very simply, quickly here, lub-dub. If you look in the extra section of the cardiac section, it will have a YouTube video explaining heart tones, but lub-dub is essentially S1, S2. We should not hear a third syllable. Like, when we listen to heart tones, it sounded like the word Kentucky. Bum, bum, bum. There's a third beat. There shouldn't be a third beat. So a third beat would be an S3. Increased venous pressure. Minor criteria, extremity edema, night coughs, dyspnea on exertion, hepatomegaly, or enlarged liver, pleural effusions of any sort, vital capacity reduced by 1/3 normal, and this would be, pulmonologists would probably tell them that, tachycardia greater than 120 beats per minute. Comparison between respiratory distress and failure. And these are always good signs to keep in your head as far as a line that I need to cross. Appearance. The person in respiratory distress is compensating. They are alert, they interact, they have good muscle tone. They may have increased work of breathing, but their skin is still pink. They have adequate perfusion. In respiratory failure, they have an altered mental status, limited or no interaction, poor muscle tone, increased or decreased work of breathing, They could have an increased work of breathing and just not be able to fight anymore, or they could have a decreased work of breathing and just be circling the drain whenever you find them. Skin, cyanotic, or pale. If you can get improvement of respiratory failure to where they have pinked up and we have sent away all the diaphoresis, then that is a good move in the right direction. They may not need to have a tube. But if you get there and it looks like it turns south, the trending on any of their symptomology looks like it turns south, get ahead of the pathophysiology. Focus exam. Head, ears, and eyes, nose, and throat. We should be looking for JVD. Chest, full chest assessment, lung sounds, how much expansion is actually occurring, if I can get a 12 lead, what rhythm are they actually in, is it coinciding with their past medical history. Abdomen, assess for ascites, serous fluid in the peritoneal cavity. If their belly is very large and it looks like it has fluid in there, that's generally from portal circulation backup, or CHF. Whenever I told you earlier that right heart failure would spill it in the periphery, that is any previous third space. That includes the peritoneal cavity. Extremities, weeping and redness on the extremities. This may be signs of cellulitis or skin infection. As far as vital signs go, manifest as a result of release of catecholamines. They could be high blood pressure, low blood pressure, or anywhere in between. If they started off in right heart failure and they're in congestive heart failure, they're probably going to be hypertensive. If they have an isolated left ventricular failure, then they're probably going to be hypotensive. Pulse oximetry readings, best used in a continuous manner to determine room air before you administer oxygen. Once we determine their baseline status on pulse oximetry, we can see improvement. End-tidal CO2 readings, and this would depend. Generally speaking, end-tidal CO2 at the point that they are retaining CO2 would be high. However, if they are in bronchospasm or they have low cardiac output, you may not see all of the cellular sampling. Now, please refer back to the capnography lecture. But low perfusion and low cardiac output could also give you a low end-tidal CO2. And then cardiac rhythms, if they're in any funky thing. If they're in AFib with RVR, they're in some sort of tachycardia or bradycardia. Please make note to that. 12-lead EKGs are generally awesome for assessing ischemic heart disease, which is a major cause of what we're talking about here, or pump failure. In the assessment, systolic versus diastolic heart failure, in the systolic dysfunction, we have low cardiac output, and in the diastolic heart failure, we generally have either normotensive or hypertensive presentations. And this would be right heart failure versus left heart failure. High output versus low output heart failure. We should also take into consideration acute versus chronic heart failure. If they're continuously in heart failure and take chronic medications for it, then very simply we need to probably assist them and get them over the slump that they're currently in. Don't be super, super aggressive, but don't let the respiratory failure go into arrest. Very simply on this, treat the patient and try to get them moving in the right direction. If we see good trending, then that'll be awesome. If we don't see good trending, then we need to probably get a little bit more aggressive. Right-sided versus left-sided heart failure. Failure of the right ventricle is going to spill it in the previous container. Failure of the left ventricle is going to spill it also into the previous container. There's not enough pressure to unload that previous container. So right heart failure, peripheral edema. Left heart failure, pulmonary edema. And this is backward versus forward heart failure, and this is what we've talked about. Right heart failure that leads to left heart failure. Table 311, peripheral signs and symptoms of right-sided heart failure. Peripheral edema, ascites, nocturia, I got to pee every 5 minutes. Jugular venous pressure is high. Hepatomegaly, large liver. Right ventricular heave and abdominal tenderness, and that would be because the peritonitis is probably occurring from all the fluid getting in there. Pulmonary signs and symptoms of left heart failure. Difficulty breathing. Every time that they lay back or they have orthopnea or change in position causes respiratory distress. Rowels. Dyspnea on exertion. Nocturnal cough. And proximal nocturnal dyspnea comes and goes. PND. Treatment, oxygenation and ventilation. We should apply CPAP. CPAP increases the pressure of the airway above what the normal atmospheric condition is. Very simply, that increased osmotic push, or that increased amount of oxygen, pushes the fluid in the alveolar sacs back into the vascular system. Non-invasive pressure support, which would be bilevel air. The difference between CPAP and BiPAP is CPAP generally provides continuous pressure whenever you breathe. The BiPAP, now on both of these we can apply PEEP, but the best thing to do on BiPAP is to add some pressure support. So they have an inspiratory pressure that you can assist them with. Very simply, if they're having a hard time getting air in, turn down the trigger so that they can get the air in easier on your ventilator, and increase the amount of inspiratory pressure that they're getting. You might want to back off on the PEEP at first, but then slowly increase the amount of PEEP. What PEEP does is it's a peak end expiratory pressure. It will hold the air pressure in the lungs a little bit, which assists putting back the fluid that's in the alveolar sacs into the vasculature. And then last but not least, if none of these things have worked, this is like a kind of a threat level thing, then try tracheal intubation. You may have to facilitate this with the use of RSI drugs and or medications that would facilitate. Examples like etomidate, ketamine, whatever's in your local protocol. Intervascular access is always essential as well. We need to get something so in case things go south, we have a direction to go. And then pharmacological treatment, decreasing the preload, things like nitroglycerin. If we have paste, we can put paste on once we've established that their blood pressure is fairly stable. The squirts or the sprays or the tablets work pretty well up front. Furosemide is a diuretic. Can take up to 20 minutes to start working the way we want it to. Removes fluid from the third space. Morphine sulfate in these cases. Morphine is a narcotic opiate that decreases myocardial oxygen consumption. So by giving the patient that's in heart failure morphine, we essentially turn their heart into a compact car is the easiest way. If it was a gas guzzler before and their oxygen demand is way through the roof, by giving them morphine, we relax them down, remove less catecholamines in the body, and then turn their heart into a compact car or make it to where it uses less oxygen or decreases myocardial oxygen consumption. Pharmacological treatment, decreasing afterload. We can use things like ACE inhibitors if we have them. Generally not the oral tablets. There's a captopril dosing that is IV that we can use. Angiotensin converting enzyme inhibitors stop the conversion from angiotensin 1 to angiotensin 2. If we don't get angiotensin 2, we don't get vascular constriction. So very simply on that, we decrease the amount of afterload that the heart must work against. And other medications to reduce afterload pressure may be things like antihypertensives in nature. The nitroglycerin, it pretty much works on the preload. But if we had somebody that was tachycardic, we could use something like labetalol. There's a few things here. Heart failure, what you do not want to do, I'll make this nice and simple. What you do not want to do is to bring in a medication that would decrease, even though I said labetalol, that would decrease the amount of contractile force strength or the efficiency of the pump. We would want to pull in a medication that will work primarily on the vessels if we're trying to decrease the afterload. And then, last but not least here, inotropic support. This means that we're going to make the heart beat harder, faster, or stronger. Dobutamine is an easy inotrope because it doesn't really increase the heart rate. It increases the contractile force strength. So, treatment summary, we should always reevaluate the cause or what we think the cause of the chest pain is. And then focus on that and try to get ahead of the physiology. Evaluation. Continually reassess the patient, and this means Q 2 to 5 minutes. If things are going south, if you reassess them quicker, essentially what you're going to see is you're going to see a trending towards the south, so you'll know whether or not to bump it up to the next level. Consider serial 12 leads. If we start to see ischemia, this gives the cardiologist on the other end awesome history from a healthcare provider so that they can actually get them to the cath lab if necessary. And considerations are respiratory failure, cardiogenic shock, do I think it's pump failure, and then the stressors of transport. Be as gentle as you can during transport. Temperature changes, noise, vibration, fatigue, gravitational forces will all have an effect on your patient. As far as the cardiogenic shock, maintain cardiac output. As far as respiratory failure goes, if you see respiratory failure, get in front of it before you have respiratory arrest. Risk versus benefit on your assessment and your implementation of intubation. On the disposition, take them to an appropriate hospital. Important decision. If you think it's acute, you're going to need to take them to a hospital that has interventional cardiology, or they have the ability to provide them with a stent if necessary, or an angioplasty. Mechanical circulatory support, ventricular assistant devices may also be considered. A couple hospitals in the metro Oklahoma City area that, primarily one, but hospital that has implemented in and puts in ventricular assistant devices. But they're essentially mechanical hearts that assist the left ventricle. And then in the temporary setting, we can always throw in an IABP, an intra-aortic balloon pump. What that does, and I'll just kind of explain that. I'll see if I can find an LVAD video for y'all and put it on the same site as your... Yeah, that was all nice and crooked, wasn't it? Okay, so this is the aorta. This is an IABP, or an intra-aortic balloon pump. What an intra-aortic balloon pump does is it's tying with the ejection that's coming out of your left ventricle, and it blows up here. Now, how this works is it works in two ways. Since it is in your aorta and you have already ejected, as soon as your ejection stops, so that it doesn't beat up your heart, it does two things. It blows up from the middle and outward. What this is going to do is this is going to provide back perfusion to the coronary arteries and perfuse the heart better, making the pump more efficient. And it will assist what you have ejected and help send it further. That's what an intra-aortic balloon pump does. Now, the LVAD, and they have LVADs, RVADs, they punch a hole in your ventricle and put it on a pump so that what the LVAD does is assist. It's a left ventricular assistant device. And I'll see if I can find a video to put in the extra section. Alright, conclusion. Heart failure involves many different systems, results from a number of causes, and there's a multitude of causes. Respiratory could have got you there. Blood pressure could have got you there. Dilated myocardium, heart attack, multiple things. Paramedic must obtain accurate history and assessment and must look at various differential diagnoses. Determine if the patient is having heart failure or is in heart failure criteria. References for this lecture have been taken from Myers Professional Paramedic Volume 2, Medical Emergencies, Maternal Health and Pediatrics of Del Mar Learning. And if you have any questions concerning this, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.